Hello, I'm Donna Bliss, Chair of the ICS Nursing Committee. I would like to welcome all our participants to this ICS Live webinar, Continence Nursing During COVID-19, Adjustments and Implications for Future. I am very happy to welcome our panel of continence nurse experts from around the world who will describe their professional practice and adjustments in response to the COVID-19 pandemic and implications for the future. The panelists will discuss challenges, adaptations, and successes, as well as impacts on patients, families, and students in various settings, from clinic-based care to nursing home or long-term care through education. Our experts include, in addition to myself, Frankie Bates from Canada, Tamara Dickinson from the US, Joanne Dean from Australia, Joe Booth from Scotland, Gilbert Liu from Hong Kong, China, and Veronika Geng from Germany. Each of our presenters will do a brief introduction to themselves in response to our first question. And so I would like to begin with Frankie and Tamara. Can you briefly describe your position, practice, or work and setting before the COVID-19 pandemic, and how long you've been in that position?
Well, I'm a nurse continence advisor. I've been practicing in an outpatient urology clinic in St. John, New Brunswick, Canada. My primary focus is lower urinary tract dysfunction in men, women, and children, as well as sexual dysfunction in men. I've worked here close to 30 years now when my colleague and I first developed this clinic.
Tamara?
I'm a continence nurse that has been in the field for about 30 years, but I went back to school and got my graduate degree, became a nurse practitioner. And I've been in this outpatient clinic in an academic tertiary care center in Dallas, Texas, for 3.5 years, working with prostate cancer patients who are in long-term follow-up and also receiving radiotherapy for their prostate cancer. So I do a lot of symptom management, a lot while they're on treatment, and I do a lot of independent clinic long-term follow-up with my patients, managing voiding issues as well as erectile dysfunction as well. So
Frankie and Tamara are going to describe their practice in outpatient clinics. And for those of you who are participating at any time during this webinar, if you would like to share your experiences or make comments or ask questions, we ask that you type them in the comment box below the video, and we will address those at the end. And as you can see, we're taking an interview type format where I'm asking the panelists a question and they will be giving short answers. So my first question to Frankie and Tamara is, what changes were made by your workplace in response to the COVID-19 pandemic? Can you briefly describe those?
Well, before COVID, we would accept referrals from physicians. We bring our patients in for a complete evaluation, and that would be history, physical. We had a full breakdown of their surgical medical history. We would be able to see their mobilization issues and any cognitive dysfunction, and we would always do a complete physical and internal examination, including pelvic exam. If caregivers were required to be with the patients, we would strongly recommend they come and they would be part and parcel of their care. So during the initial stages, for sure, of COVID, during our lockdown, we weren't allowed to see any patients that weren't considered urgent. In fact, Most of our outpatient clinics were closed. We were one of the very few that remained open because we had a lot of urgent cases. We had narcotics, we had urinary retention that we have to teach CIC. All our operating rooms were closed, all elective procedures were cancelled. Many of the staff were deployed. Fortunately, we weren't. We were allowed to stay in our clinic. The unfortunate thing was anyone that was incontinent wasn't considered urgent, even if they had grave maceration and skin issues. And so we decided at that point very early on that we would conduct either virtual interviews or telehealth interviews instead of appointments, so at least we could follow with our patients and their caregivers. Other changes are we had to change our waiting rooms around for social distancing, so we had larger gaps between patients. And again, with the beds and the examination rooms and just trying to get everything clean, like if a patient sat on a chair, we had to clean in between. So it was all like very stressful and still is, and a lot of time commitment that we didn't have to consider prior to that.
Tamara, would you like to add to that?
Yeah, so the university acted very quickly and swiftly initially, and we have on campus about 19,000 employees, and probably 85% began to work remotely. Any routine follow-up visits were converted to telemedicine, either video or telephone. All the imaging on campus was halted. Non-urgent procedures, any elective surgeries, everything was stopped. I began working from home the third week of March and didn't return to the clinic until June 15th. And now I work in the clinic Monday, Tuesday, and Wednesday, and I do telemedicine on Thursday and Friday from home still. In some ways, because we're a large tertiary care center, a lot of our patients come from very far away, sometimes, other states, sometimes, Texas is a large state. You can drive 10 hours and still be in the state of Texas. So many people who did come from far away like the telemedicine, and we're going to continue that in the future. Because it's much more convenient for them. So some of this is likely to go on indefinitely. We have in the radiation oncology clinic at UT Southwestern, we treat about 250 patients a day. We do all of the radiation therapy for the county charity hospital as well. So we have a very wide variety of people who don't have access to technology to be able to do the video visits. So some of them have been strictly telephone call. It's been, like Frankie said, extremely stressful. In the last 3 weeks, we've had an incredible resurgence of cases in the state of Texas. The system is extremely taxed. We have entered it within the state phase 3 out of, I believe, 4 in terms of reopening. The university has halted at phase 2 for an indefinite time. Our president made that announcement yesterday. So I'm not sure. The system is extremely taxed. The two major cities in the state are the Houston area, and Dallas-Fort Worth, where I am. And we are quickly running out of critical care beds. It's becoming a bit of a crisis. Our governor finally, I believe last week or so ago, mandated masking finally within the state, but there are still a lot of people who don't want to do that. So it's a very stressful time right now. And just in the last couple of weeks, things have changed. We are now wearing face shields as well as masks within the clinic.
Thank you. Frankie, what challenges or issues have, I guess, what are some of the main challenges and issues that you have faced in your setting, and how have you managed them?
Yeah, well, lots of challenges for sure. Like I say, I was able to continue working my clinic throughout very early stages of COVID. I would either see urgent patients or do telehealth, but my colleagues were not allowed to be in the same room without our facial masks. So of course we had to eat all our meals alone. So we lost some of that social part of nursing too, I guess. Days were a lot longer. In fact, they still are a lot longer. And now we're seeing patients, we're trying to see them behind a mask. Some of these patients are elderly, they get quite short of breath and overcome with the heat under the mask. And many of them, like even just to try and drink a glass of water, and I'm teaching all day and educating and talking behind this mask. And just to have a glass of water, I have to walk to the far side of my clinic, take off my mask and have a sip of water, put it back on again and go back. So just not having eye contact with the telehealth patients was difficult, because I think a lot of the time as nurses, you know, we get the trust in our patients, you know, when we first assess them and see them, and you know, they allow them kind of in to see how we're going to look after them, how we care for them. And it's very hard to bring that over on a phone interview without that eye contact, as well as kind of using the visual cues. You know, I use a lot of diagrams, and kind of show them and color in and explain what's going on. And so I would have to send those ahead of time by mail, so at least they could try to see and visualize what I was trying to teach them. So that helped a bit. And like, I think every day initially there was another issue, and now it's more like every week there's a new issue. So it's getting a little better here. Things are easing up.
And Tamara, when we asked for some questions, you had also mentioned some difficulty in your patients with some of their hearing ability. Do you want to comment on that?
Yeah, so, you know, I deal with prostate cancer patients. And so the average age in a clinic for me is 70. I have patients as old as, you know, 92, 93. I have a 90-year-old patient who plays tennis 3 times a week still, but it's very difficult in the clinic sometimes talking with these gentlemen who do have hearing difficulties, and you're behind a mask, and like Frankie said, it gets difficult, you know, talking all day, you know, the trying to amp up your volume behind a mask all day is difficult. We're not wearing N95 masks. We're just wearing, you know, surgical masks, but it's still difficult. And you know, there's a lot of, I didn't realize how social of a person I was until I had to work from home for 3 months, and found out that it's very difficult being home alone all day. My husband was still going to work, and in the, you know, in the warehouse facility where he is. And so it was very difficult, cabin fever. And I think that we've all had more than our fair share of that. So, but yeah, the talking, and then talking on the phone. Just yesterday, I had a great bit of difficulty, because even sitting at my desk in our cubicles, we have to have masks on, even when we're not in the clinic. And trying to talk to someone over the telephone who's 70 something with a mask on, you know, was very, very challenging, without, you know, screaming where I was disturbing my colleagues sitting next to me. So.
Frankie, I just wanted to ask you to describe some of the adjustments you made with some of the continence specific practices in terms of assessing leaking, teaching pelvic floor exercises. Can you address those?
Yeah, so usually, you know, prior to the COVID pandemic, I would bring my patients in, and after assessment, so I would need to assess like their weight, their height, the degree of leaking that they would have, or the type of leaking, whether it was stress or urge incontinence, and the degree of leakage they had, whether it was at night or during the day. And from that, I would show them different products and recommend a product, whether they'd need a full brief or a simple panty liner kind of continence product. So this, of course, became more difficult over the phone. I would have to try and assess it by asking their height and weight and when they were leaking and what product they were using. Was it a menstrual product or a bladder product, and how often they were changing it? You know, was it wet, damp, or soaked? So it was a little more difficult that way. I have been using the product companies a lot more. A lot of them have systems intact that you can put the patient in contact with them and they will help send out products, because now we're not even allowed to give any products to our patients. Nothing's allowed to leave the hospital or come in except for the patient. So all of that's more difficult, and we're still kind of ironing through those problems. For the catheter problems, that was a nightmare also, because typically I would suggest either a hydrophilic coated catheter or a non-coated catheter or a coude or a straight catheter. And that was very problematic for me, because it was hard for the patient to assess what they needed. So again, we're working through challenges like on a weekly basis.
And how about the pelvic floor exercises? How do you approach that? Are you able to use video or?
Yeah, so initially we would send out pamphlets, education pamphlets, describing the pelvic floor, and phone the patient, ask them to read through everything prior to our phone visits. We would have to do everything, of course, by phone, which was very difficult, because normally I would do a pelvic floor assessment and I would have a look at how strong their pelvic floor was. Are they able to endure a hold for how long they're allowed to hold their pelvic floor for, able to, the strength of the pelvic floor bilaterally. So of course I was missing all that, whether they could do slow twitch or fast twitch exercises. And so it was all became a big guessing game. So I was able to, initially with the hospital, none of our computers, and even today I have to bring my laptop in, my tablet in, because with our systems, we're not allowed to have any video or audio on our computers, but they have us to use our laptops now, and so we can do video follow-up. So that helps a little bit, but it's still not the same as doing a physical assessment and internal assessment on patient for sure.
You both had mentioned some challenges with laboratory tests and values that you normally would like to have. Tamara, do you want to tell us about that?
Yeah, I mean, you know, I follow prostate cancer patients, and PSA is how we track that. We also manage, you know, if a patient has a UTI and things like that, you know, urinary tract infection, and trying to get some of these elderly men to feel safe to go to the lab to leave a urine specimen or to get blood drawn was very difficult. And especially in the early stages when, of course, everybody felt like it was just going to affect the elderly. And so they were even more keenly aware of, you know, not taking risks and all of these sorts of things. The lab on campus did a pretty good job about making, instead of, they would not take any walk-in patients. They were all made by appointment. They spread them out across the 6 or 7 labs that were on campus. They, you know, really controlled the traffic within each, you know, lab. Sometimes when you would tell patients that, they would feel more comfortable about making the appointment to go get labs done. But some of the community labs were not taking those same types of precautions. And so, yeah, it was hard to talk some of these elderly folks into going to the lab for things.
Tamara had mentioned some positive change, perhaps that the telemedicine or some of the video distance consultation might continue. Have you identified some changes that you think might be a positive for the future for you, Frankie?
Yes, and I definitely agree with Tamara in as much as some of the changes we will continue to do with telehealth, but some of them will still have to be seen and assessed. But especially for my out-of-town patients, I agree completely. We will do them by telehealth. Some of my patients that would come in for pre-op cancer treatments and teaching of catheter care, if their patient was sick, if their loved ones were sick and unable to come to the meeting, they would miss that meeting beforehand. Now we set them up, the patient sets their phone up and the loved one sets their phone up at home, so they're included in their educational appointment with me. We have our pelvic floor physiotherapist who does physios for like core strengthening and balance. It's been really effective, so we're going to continue to align with her for that. So some of the practices we will certainly continue to. I guess there are a small, tiny little bits of positive attributes to COVID.
Mm-hmm. So my last question to you both is about your patient and their caregiver or family coping. What have you noticed as their major issues and concerns, and how have you been trying to address them?
Well, for me, certainly not having the caregivers or loved ones, sometimes we are allowed to pre-authorize now because we're in level 3. We are allowed to pre-authorize a caregiver or loved one to accompany the patient, especially if they have mobility issues or cognitive dysfunction. But sometimes they'll turn them away at the door. For instance, I had an 18-year-old yesterday with dyssynergia, and she had huge medical issues as a child, and I wasn't really able to get that history because her mother was turned away at the door. Sometimes a patient may not have a caregiver, but are living, like the day before yesterday, I had an elderly patient, terminal. Usually his daughter would accompany him. I was trying to teach him how to self-cath, and he just became completely overwhelmed and really began to tear up. And I just felt like inadequate as a nurse, that I couldn't really make him feel better. I wanted to sit down beside him and rub his back and make him feel better. And I actually did end up re-sanitizing my hand, putting gloves on and doing just that, because I feel there's a large part of nursing that we're not able to show anymore. Not that we're Florence Nightingales or anything, but we want to give that empathy and sympathy and make our patients know that we feel and understand what they're going through. And I think we're missing that too.
How about you, Tamara?
Yeah, I agree. I mean, I miss hugging my patients. You know, it just that little thing sounds silly, but I do. I love those guys, and I miss, seeing them face to face. I had one patient on a video chat, much like this, tell me that it was good to see me, but he didn't like seeing me that way. Mm-hmm. So, and then we've been pretty fortunate. We've allowed in our consultations, we've allowed one family member to come in with the patients. The treatment, if the patient's able to come alone, they want them to just be the sole person in the building. It was all much more strict until a few weeks ago, mid-June, and it's not gotten more restrictive again, but I'm concerned that it's going to because of our surge in cases. So, but it's
possibly that change might be difficult for patients to go back to.
Yeah, and staff.
Sure. Well, thank you both very much. If anyone has any specific comments for them, I encourage you to type them in the chat, because I'm going to now pose some questions for Joanne Dean from Australia about her experience with long-term care. And Joanne, again, could you briefly describe your position, your usual practice and setting, and how long you've been in that position?
Sure, thanks, Donna. So I have two continence-related positions. My primary position is as an endorsed nurse practitioner for Prescribing Health, which is located in Canberra in Australia, which is our capital city. Prescribing Health provides general practitioner, or I guess what you would call primary care physician services, to patients in long-term care facilities and to elderly, housebound and disability patients. And I've worked in that position for about 9 months. The other position that I hold is as the clinical lead for the Continence Foundation of Australia, providing clinical supervision and assisting with clinical governance of the National Continence Helpline. I've been doing that position for about 12 months. And prior to all of that, I've got about 35 years experience as a nurse continence specialist across a whole range of different settings.
Wonderful. So could you describe the precautions that have been instituted in your area for long-term care homes and the success of those changes on the COVID-19 rates and deaths in your area and country?
Yeah, so things have changed a little bit for us in the last week. At the time, in the last week, in preparing for this webinar, one of our states, Victoria in the south, has experienced a significant increase in community transmission of COVID-19. And that's resulted in that state having a return to stay-at-home restrictions in Greater Melbourne and some outer shires, and there's only 4 reasons people can actually leave their home. And all state borders are now closed to that state, except for people with permits, and self-isolation is a requirement if people attend. So I think, unfortunately, with that increase in cases, which as of 9 o'clock tonight stands at, I think it was about 175 new cases there today, we're now starting to see new cases emerging in particularly staff working in long-term care and in healthcare settings across Victoria. So that's not something that we've really experienced to date. There's been a few small clusters and a couple of facilities that had outbreaks, but they were contained. And community transmission was not an issue for us. Just since the 20th of January, we've now done nearly 3 million tests, of which only 0.3% have been positive. Currently, 45 people are in hospital and 10 are in intensive care across the whole country. We've had a total of 9,059 cases, 106 total deaths, and 7,575 people have actually recovered. In terms of how we've managed in the setting that I work, I'd just like to acknowledge Anita Francis, who's an ICS member, who's provided me some information of the national overview of the COVID-19 response in long-term care. Australia has a national regulator for long-term care homes called the Aged Care Quality and Safety Commission. The Commission contacted every long-term care facility and assessed their infection control practices and their readiness for COVID-19. Homes that the Commission considered high risk in relation to their infection control then had a site visit from the Commission's quality and monitoring staff. The Commission partnered with government and public health units to respond rapidly to any suspected or confirmed COVID-19 cases, and that included ensuring there was access to PPE and extra staff if staff of the facility had to self-isolate. They also partnered in developing resources and tools to assist long-term care homes. High test rates and tracing has also occurred. Many long-term care homes went into lockdown and restricted visitor access early, which was actually more than what the government recommended. It's been a requirement for entry to all long-term care homes to provide evidence of current influenza vaccines since the 1st of May 2020, and that applies to all staff and visitors. And there's only 2 absolute contraindications to that requirement: if someone's had anaphylaxis after a previous flu vaccine or anaphylaxis after any part of a flu vaccine. There are no other exceptions. If staff or visitors meet those criteria, they've got to wear a mask when they actually go into the facility. Evidence has got to be cited prior to entry, and actually one of our GPs refused entry to a facility recently because he didn't have the evidence with him. So they were really very strict on it. And that the reason for this was to reduce the burden of influenza outbreaks on health systems and reduce the chance of concurrent infection, particularly in a very vulnerable age client group. And at this time, our influenza rates are very low. and we're not yet at the peak season here, which is probably the end of August. But, you know, I think with the increased hand hygiene, we're testing every time we do a COVID test, we're testing for other respiratory viruses as well. And there's essentially a flat line at the moment. So we've had a really low threshold for testing of COVID-19 in long-term care. So anyone with either a fever, any respiratory symptoms, including cough, sore throat, runny nose, who lives in a residential aged care facility is tested and isolated until results are available. And that's meant for some people, they've gone in and out of isolation a few times. The tests are coming back quite quickly now, which is good. Asymptomatic people entering care or returning from hospital aren't required to be tested or isolated if the reason for hospital was not related to COVID-19. But in practice, depending upon the facility policy, residents might be isolated for a very length of time. And I think I go to 8 facilities across my working week, and there's not a consistent approach to that in any of them. It's very variable. So the other thing that is in place is that there's a requirement for self-declaration for entry into residential care for visitors. So visitors who have returned from overseas in the previous 14 days, and we're still asking in some places people who, have you been on a cruise in the last 14 days, which just is quite amusing really, because I don't think anyone has been. If they've returned from a known hotspot in the previous 14 days, have a fever above 37.5 and temperature testing at entry is widely in place. If they've been in contact with a known or suspected COVID-19 case in the previous 14 days, are caring for a family member with respiratory symptoms or have any respiratory symptoms, you'll be denied entry to the facility. Visiting restrictions have been easing across most states of the country, but you know, I think that may start to change again following the clusters in Victoria and the border closures.
So how have these restrictions impacted your practice? You had mentioned that you care for individuals in several different facilities. How have you adjusted?
So during the stay-at-home orders, my work changed to primarily telehealth using video. There was governmental changes introduced to billing arrangements, which meant that we could bill for primary consultations using telehealth, either telephone or video via Medicare. The practice that I work for made a decision to switch to video consultations very early on before it was a requirement. So we got a bit of practice in. It was something our practice had been considering previously, but financially you couldn't bill if you were in the same area where you're going to do the consult. So that was a significant change. So over a 6-week period, when we were in stay-at-home orders, I attended the long-term facilities. On average, I'd go maybe once a week for an issue that required further assessment and or clinical examination. So other practitioners within our practice maybe went more than I did. They were working more days, and if they were already needing to see someone in a facility where someone needed to be seen, then obviously I would ask them to follow up the person there as well, so that we didn't put more people into a facility than we needed to. We've got a very team-based and collaborative approach to care, so that worked very well. I really missed the face-to-face contact, both with the residents and the staff that I usually work with. The platform that we used was very simple platform to use, but for the RN on the other end, there was a lot more work involved, so consultations did take longer than normal. We'd begin with a review of the clinical issue for all the residents that were needing review. We used a remote online form called a SNAP form. They would fill out with what the clinical issue was. Both the primary physician and myself would get a copy of that form, so I would know what the issue was when we were ready to talk. It would mean that before I did the consult, I could log into the facility system remotely. I could look at their care notes, I could look at the care plans, the vital signs, any clinical photographs, for example, of wounds or IASD, and medication charts prior to the consultation. The RN, after we'd had the discussion, would then carry the device to the resident's room and we would do the face-to-face consultation there. where the person wasn't able to cognitively participate in a clinical discussion, it really still gave me the opportunity to visualize the person and know if there was any deterioration or physical signs. I've been seeing these people for a while and I know them quite well. We could do notes and remote prescribing, where prescriptions and medication charts would be uploaded directly to the pharmacy system that would then dispense and deliver the medication. I usually work with the staff, so generally I knew what their skill level and reliability with symptom reporting was. When I was unclear or unsure that I was getting all of the information, I would then either do a face-to-face consultation afterwards to confirm for myself what was going on. As I said, request one of the other practitioners to review if they were going to the facility. And fortunately, we also, in a lot of facilities, and I had here access to a team we call the Grace team. They've got different names. Essentially, they're a conduit of RN care between the emergency department and the facility, where if there is an acute clinical issue that may have required hospital transfer, the Grace team will come in and try and manage the person in the facility. So I could utilise Grace for things that needed perhaps more expert input to. Because they were already there in the facility, again, it meant there was not myself, another person needing to go in and increase exposure.
We hear from here in the US and other places that the changes and the concerns about COVID have created differing levels of stress and concern. In long-term care, the residents may be seeing some of their co-residents getting sick or dying. What have you noticed? And maybe what are some of the responses of some of the staff in those facilities to these stressors and concerns of the residents?
There's been varied stories from long-term care. Families who provide essential care to their loved ones have had concern that the facilities haven't had the staff to replace the care that they would usually provide. So, you know, if they went in and helped give the person their dinner, there was a lot of concern that if they went there, that person wasn't going to get adequate nutrition, that they would just be left. Visitor restrictions was one of the largest area of concerns for families, and the Commission has a complaints hotline, and there was a significant rise in calls about visitor restrictions to long-term care. Visiting has still continued with restrictions such as isolation, social distancing, increased hygiene measures, also, as I said, with all the requirements for entry to facility, and restriction of children under 16 from entering long-term care. But where I am here in Canberra, that is now lifting in some places this week. I'm starting to see a few kids in the facilities again, which you know, means a lot to those grandparents who've desperately missed their families. Visitation has occurred through a number of innovative ways. I think that's worldwide, outside, virtually, using apps such as FaceTime and Zoom. And social connectivity has occurred in new ways, virtually, and with school children writing letters to long-term care, for example. The challenges, I think, with using some of those different ways of communicating and managing people from a medical point of view raise some issues that impact on the success or failure of the system. And I think one of the big ones is the optimal internet availability and reliability. And that was very variable, even within a particular site. So I could have a good consult with the nurse in her office. The minute we tried to go to the resident's room, we'd be dropping out and having all sorts of trouble. The other issue is the device screen size and volume at the consumer end. So for the resident, if there's a phone or a tablet, it's not a big screen, the volume's not really loud, and that can become a real problem when you're trying to communicate with people. And obviously the sensory issues like vision and hearing have a big impact, and the cognitive issues like, you know, comprehension, interaction and engagement. One of the things I noticed I did seem to be doing a lot more of during this was actually looking in people's ears because they really weren't able to hear what was going on. And the first thing we needed to do was make sure we weren't dealing with impact of wax stopping a hearing aid from working, for example. I think I've found that it's been a really challenging and at times quite amusing way to work. So there's been successes and failures. There's the residents that get up and walk off in the middle of a consultation when you're saying something to them, and the ones who walk up and poke the screen, or they think I'm their daughter, or, you know, it had a lot of things that went on. An example, I think, of something that was really successful in this situation was I had a request to consult with someone in a facility I didn't normally go to who was having issues with their catheter spontaneously expelling with an inflated balloon that was becoming really problematic. So I was able to use video, and there was a really wonderful and knowledgeable RN on the other end. And, you know, I was able to get a background history. I could oversee an examination being conducted by the RN to exclude any contributing factors. I could actually visualize the catheter to determine what material and size it was. I could review the records, discuss the plan, do follow-up consults, and do a referral onwards, whilst providing a management plan we could use until urology review could occur. This resident and RN both gave consent, and their organisation gave consent to give a little bit of the feedback of what their experience was using this. And the resident said that it felt more human to her during this difficult time. She said it was nice to have eye contact and to be able to express what she was feeling around her catheter, as it felt more personable, particularly since her specialist wasn't able to see her during COVID. For the RN, she said she felt more confident having video because speaking on the phone can sometimes lead to miscommunication or communication breakdown if things aren't heard properly. She felt it was more collaborative approach and patient-centered. And she said that at one point, you know, there was myself, the power of attorney, herself, and the patient all in a virtual clinic room together. And we all heard what was being discussed. It allowed for input from everyone. And she felt that that was very collaborative and helped them meet their goal of timely referrals, which have been greatly impacted by COVID. And I can compare that to another facility I work with that really did not embrace the telehealth option. And I had issues on that end with variable skill levels of the RN providing the information, and the reluctance of the facility to provide the tools to enable the telehealth to work in an optimal manner. So staff would use their own phone, which had a really small screen, which the residents couldn't use. English language was a barrier in some staff consultations, and normally in that facility, I need to actually watch the staff when I'm speaking to see their response so that I can be sure they're really understanding what I'm saying and that we're using talkback, because otherwise the right things aren't getting through. And at this facility, they wanted me to use the telephone, which just complicated the consultations. And then they would ask the person to speak with me on the phone, which is a requirement for Medicare billing. I need to involve the consumer. And if the person had cognitive issues or hearing impairments, they had no idea who I was on the phone and what I was doing. So in that situation, I usually ended up having to go face-to-face, which wasn't ideal if it wasn't a necessary consult. But again, I did use the Grace team to provide in-reach support in those situations to go and have a look at the residents and let me know what was really going on.
So just to wrap up, have you heard of some potential innovations or changes that you think might continue after the COVID surges, in addition to maybe some of this video?
I think with the telehealth, I think within our practice, we want to see it continue. It does provide the ability to improve our work efficiency because it enables remote consultations, acute reviews, and quick response times, which when you're looking at general practitioners or physicians, they usually have another practice that's clinic-based. Our service is a little different. We're totally based within residential care and don't actually have a clinic. But for other GPs to get to a facility when there is an issue, when the staff call, you know, that's not always possible, and there can be delays in prescribing and treatment. So our belief is that if we can continue to use telehealth, we can address those shortfalls where the practitioner, won't need to leave another place of practice and travel to the facility for an urgent consultation, and that provides, better care to those people there. Until the end of September, telehealth will continue to be a billable item via Medicare for general practitioners and nurse practitioners, and we're hoping that will continue. In terms of family communication, we were able to use the telehealth platform for family meetings in a virtual clinic room, and we intend to continue to use that moving forward, because it's much easier to get everybody wherever they are in one place using that. And I think I would hope that the Grace team role continues to expand more into residential care, because that was really an essential key link in the whole process. There's been a greater focus on advanced care directives in residential aged care here during COVID-19. And I think that I've really noticed a reduced, people aren't so quick to transport people from residential care into emergency departments throughout this. And I would hope that that continues, because there have been a lot of things we have managed in the facility that before they would have been sent into ED before we even got there.
Well, thank you very much, Joanne. And I would like to invite Joe Booth now to join me, where we're going to talk about nursing education. My background is that I am a professor at the University of Minnesota School of Nursing in Minneapolis, Minnesota in the US. I am the director of the PhD program and the director of graduate studies at our school. And I've been there on faculty since 1992. Our university has a PhD program, a DNP or a Doctor of Nursing Practice program with 12 specialty tracks, and 2 pre-licensure programs. One is a traditional 4-year baccalaureate program, and the other is a 16-month professional master's program for students who have a bachelor's degree in another non-nursing field, and then they would finish our program and be eligible to take the RN licensure exam and become a nurse. So Joe, would you introduce yourself, please?
Yeah, sure. My name's Jo Booth. I'm a professor of rehabilitation nursing at Glasgow Caledonian University in Glasgow in Scotland in the UK. I've been at Glasgow Caledonian since 2004, so quite a long time now. I am also responsible for supervising PhD students. I think we have a slightly different system for doctoral students in the UK compared to the US and some other countries. So we have individual students that we supervise as directors of studies all the way through. So I have a number of them. And we also run a professional doctorate program at Glasgow Caledonian University, which is for any allied health professions, as well as nurses. With regard to the undergraduate nursing, we run 3 pre-registration courses. We have a 3-year degree program. We have a 4-year honours degree bachelor's program. And we also have a master's for graduate nurses, which is 2 years in length. We also run a number of taught master's courses. So that's things like the Masters in Public Health, Masters in Advanced Nursing Practice. And as I say, we have the professional doctorate as well as the traditional PhD route to doctoral study.
So in terms of the changes that my university made in educating nursing students, be they general nurses or any of those who might be specializing in continence related areas. Like Tamara said, the COVID infection was really made itself known in the US in mid-March, and we were at spring break time, and our university extended spring break for a week and then made the decision that no students who were off campus were to return to campus. And those who were on campus who maybe did not go home or away for spring break were asked to go home if at all possible. And so all in-person classes were canceled, and we changed to doing our didactic classes through remote synchronous courses using Zoom, the way we are doing now on this call. And some of our courses already were online asynchronous courses. And so faculty could use a combination of either of those approaches. In a few weeks, the university actually closed its campus for essential personnel only. And I think one of the largest changes that we had to face was that all clinical courses for our students, not only nursing students, but medical students, pharmacy students, were stopped. And so to assist our pre-licensure students with clinical learning, we use various virtual approaches. We use standardized patient interactions with Zoom that could be facilitated without too much modification to those we already use with standardized patients. That's where an individual who would be sort of an actor or model would act as a patient. We call them standardized patient with standardized scripts. So they were easily able to pivot to that through the remote platform. We did recordings of standardized patients that we had banked. We did either recordings or virtual interactions with some family members of some of our faculty who would do role playing with scripts and who did some practice to increase the number of interactions and cases that we have with students. We did telehealth simulations, and we also did some online virtual screen-based simulations. One of the things that we use simulation quite a bit and standardized patients quite a bit. And one of the things that, one of the approaches that we have been emphasizing this past year, which was very timely, was planned debriefing, using the debriefing for meaningful learning method. And that had worked really well with these virtual, remote, or standardized cases where the student would have to talk through their clinical reasoning and clinical judgment with the faculty in a reflective and informative dialogue. And then the faculty would, make an evaluation or assessment and give feedback to them. We recently changed to the Zoom platform, so we were able to take advantage of breakout rooms for small groups so that students wouldn't have to be sitting in front of their screen for some of our 3-hour classes and get bored. So we were able to do some active learning strategies with some of the strategies that actually the technology of Zoom afforded us. And our DNP students were very used to doing OSCEs, which are objective structural clinical examinations that are performance-based. And so they were able to do those virtually and remotely online. So I would say our DNP program, which is based primarily online, was in a very good position. And other than being restricted for clinical hours, which they will need to make up going forward, they were probably the least impacted, whereas our pre-licensure program, the bachelor's and master's program, probably those students had to make the greatest change because those are in-person classes, and they had to switch over really in a short time to become more virtual and remote and using technology. How about you, Joe? Could you describe what the experience was at your university?
Yeah, sure. I think there's probably quite a lot of similarities, but there are some differences as well. We don't have a spring break, but I think it probably all happened around the same time at the beginning of March. And basically, all of our face-to-face teaching was suspended for 1 week to allow everything to move to the remote platform. So we generally have a blended learning approach to most of the, certainly all the undergraduate education and a lot of the postgraduate education. And we use what's called the flipped classroom, which I'm not sure how many people use that, but it's where the materials and a lot of the learning activities occur. The student will self-direct So the materials are presented virtually online through our virtual learning environment, which is Blackboard. And they will do much of this work and a lot of the activities and then come to class. So it's called the flipped classroom because it's the opposite way around, really. We've been working with that system for about 3 years, and it works, it's variable really with how the students respond to it. But there seems to have been a very, very positive response with things happening so quickly with the COVID-19 situation. Many of the students have really embraced the flipped classroom, perhaps more so than previously, and some of that is in response to the fact that it's so flexible and it allows them to continue with some of the challenges that they have in their own lives, such as childcare or caring for others, or perhaps being needing to socially isolate themselves. So they've been able to continue to do that much more readily. So for our online classes, we've tended to focus very much on using a lot more of the software that's available. So we're using a lot more of the interactive PowerPoints, such as Turning Point, and Collaborative Ultra, which is the Blackboard virtual learning environment collaboration suite. And we're using a lot of Padlets to engage students of all levels. For us particularly, it was perhaps fortunate that we were actually at the final stages of our trimester, which meant that most of the clinical skills learning and teaching for each year was actually coming to its end in the university, and we were embarking on the consolidation phase for the students. So using resources such as Camtasia and the different functionality that's in that to allow us to pause videos and pause pre-recorded films, this became a real advantage for us in allowing students to reflect very much on their practice. So similar to what Donna was saying about using pre-recorded consultations with patients and with family members, we were able to incorporate a lot of that into the education. And we do quite a lot of synchronous learning with the students at the moment, and have done for the last few months, using a lot of these interactive resources, particularly interactive PowerPoints.
Now, we had our clinical practices suspended. I'm wondering if you could inform our participants how you address some of the clinical work of your students.
Well, the clinical work, it was all suspended. And then what's happened is that our second and third year students have been employed. So this is quite a huge change to clinical practice, really. They're employed by the National Health Service as Band 4 or Band 3 associate nurses. So this was a decision that was taken by the UK government to enable students of many disciplines to work within the NHS to support the situation with regard to COVID-19. And across the UK, this has happened not just with nursing, but with other disciplines. It's been particularly successful in some ways, but there have been challenges, as you can imagine. Our Year 3 students, most of them elected to do this. They did have the choice, but it did work very well in terms of the timing for their courses. So they were just about to go into clinical practice anyway to pick up on their clinical placements. The second years were the same, so they're now actually working currently as employees of the National Health Service. But this doesn't mean to say that their learning has stopped, because they're still gaining all their clinical skills and being assessed and supervised throughout this period, and they are still technically students. So this period as it stands will come to an end in September, the end of August for the second years, and September for the third years. So at the moment they are, as I say, fully employed. So with regard to supervising them, there is also, fortuitously, the new system in the UK, the Future Nurse Programme. So things have been changing with regard to our regulations. So the Nursing and Midwifery Council, which regulates all nursing within the UK, has just developed the new standards for student supervision and assessment, which are now being incorporated into this situation. They've been brought forward. And it's really just changed the structure and the method of assessing and supervising students in the practice areas. And so these new standards have allowed us to change that system. Just going on to other postgraduate courses, the clinical education in the postgraduate situation, so the master's programs, most of those have been suspended clinically because the staff themselves are needed in practice. They will pick up in the next trimester, which starts in September. And with regard to a lot of the doctoral research programs, what's the main changes have been that students undertaking research elements of those programs have either had to suspend their recruitment, for instance, or depending on where they are in the program, a number of students have changed the methods that they're going to use. So for instance, for many of the master's students, rather than undertaking an empirical project, many of them have elected to do systematic reviews because that's something that they can do as a desktop exercise, because there's no opportunity for them to gain any clinical access at the moment. And some of our doctoral students, again, because they're on much longer courses where it's affected things like recruitment that has had to have been suspended, there are two options. Either they can change their plans, which isn't really ideal for many of them if they're midway through recruitment. But where they've had to suspend, then the university has brought in an automatic extension to their studies, and for many students this is a funded extension, so it shouldn't negatively impact on their research studies. And this is we feel very, very important. It's also true that's the case for many research studies as they stand, that we are in an extension period for a number of our research studies as well.
I just wanted to add some information to the student research. Our university limited research involving human subjects, whether they were of PhD students or faculty. We adopted what they called a 5-tier system of priority for research. And tier 1 and 2 are for COVID-19 related research protocols. Our university is quite active in some of the research related to COVID-19. So those were tier 1. And tier 2, which wasn't really far behind, were studies with high direct benefit to research participants. So cancer patients who required going on a clinical protocol, maybe enrollment might have been more automatic before. Now they had to submit an application, but they had a quick response team to review those where enrollment was considered, high direct benefit to students. So most studies with PhD students were suspended. Luckily, we had quite a number of our PhD students do their final defense in spring. And so I would say the majority of our students are still in coursework. There were a few only who were impacted. But it was very interesting. We have some students who were using available data sets from clinical agencies. So if like hospital system, be it the University of Minnesota or the Mayo Clinic, might have a database of patients, initially we thought those students wouldn't be impacted, but the clinical sites had to really focus on their response to COVID clinically.
Yeah.
And so we found that those students actually ended up being halted as well and suspended for a time, because there wasn't the personnel on the clinical side to, assist them in providing them the data and giving them access. So I think that was something we thought we hadn't really thought about, and that was an impact. Because we are a fall, spring program, being that research is still on hold through this summer, probably doesn't impact students too much. And we hear that things in terms of research, they're reevaluating always, in terms of the models, if it's going to open in the spring. So I've been advising in my role as director of the PhD program advisors to be, as Joe said, talking with students depending on where they are. Is it possible for you to refocus and do something perhaps that wouldn't involve active recruitment to avoid some delays? So I think we're still not sure of that impact. We're hoping that it won't be so great as they reevaluate things for the fall. I guess my next question is about some of the main challenges and issues from these adjustments that we have faced. And Joe, maybe ask you to address that first.
I think for us, it's a simple thing really, that as the others who've been speaking have said, our main challenge has been sometimes limited internet access for many students and for staff who live particularly in the rural areas in Scotland. Our connection can be quite poor. On the whole, students have been very keen to engage using the different resources, and we are very fortunate that we have a very good support team in our blended learning technologists, our library services, and our learning development team, who all support students and who have been very, very active during this period, particularly the blending learning technologists and the IT support people. We have, when we closed down, everybody literally took all of their IT equipment home. So I'm sitting here with my full office set up here, and our virtual network is very, very helpful, but it's not always totally reliable. And so, these are the sorts of challenges that have been more prevalent than anything else. So I think particularly the IT challenges, as a teacher, you have to be a little bit more flexible when you find that people's dogs come in, or their young child comes in and wants to get the biscuit, whatever, and that's absolutely fine, because we're all facing very, very different situations. But you have to be flexible to that, and I think that the options for the asynchronous learning are very important as well, because going back to the idea of the flipped classroom, that means that the students are actually being responsible for their own learning and the timing of their learning, and that works very, very well.
I think for faculty, one of our challenges had to do with technology. Our university just this past year, and I really think it was in September, just adopted Zoom. We just changed over to this new technology, and so everyone doesn't teach every semester. And so for the faculty who are teaching face-to-face starting in spring semester, which would be January, all of a sudden there was a steep learning curve in learning how to use Zoom and all its different facets. And I think people were gradually, we had workshops and trainings, but we were at a very fundamental level. And there are so many different advantages and options that we really were trying to teach each other in what to do in that very short period of time. Since then, we have a Center for Educational Intervention where we have some faculty their main focus is in supporting faculty development, and they have been quite busy and quite phenomenal in offering various sessions and workshops They are they've developed them in modules, so they're only 1 hour long, or they could be over different weeks that you can partake of. And that has been a great help just for some basics, like how do you use the whiteboard in Zoom to, flexible assignments, as Joe was saying, to be inclusive in different environments. So I think that faculty were quite challenged by the quick pivot. I think we are used to planning ahead. We're planning our course for the next semester and how we might integrate these things. And yet we had to do it in 2 weeks' time with, we have some programs like our DMP program and our MM program who do have some summer classes. And those faculty had to learn very quickly. So I was one of them, just beginning with Zoom, and now it's just like, okay, I can do this. The second piece, I think, was our students who really, in terms of, were feeling a loss for their clinical experiences. They really value that clinical time. And I think one of the things that the faculty were working with was trying to help students understand and build the confidence that so much of nursing is about clinical judgment, assessment, acquiring the clinical data that you need to make decisions. And quite a bit of that can be done virtually and online and with standardized cases and patients. And that's what we've been trying to emphasize. Though I think all of us experienced where we had beginning students who really want to do that tactile skill development. And they really were struggling with their own confidence and their own idea of their education and training. Mm-hmm. We will pick up those things with some, review, laboratory sessions once we go back on campus. But we were dealing with them with that anxiety and with that sense of loss there for a while in the spring semester. And it took quite, trying to shift that focus into really what I think are the higher levels of nursing, that clinical judgment and clinical reasoning, maybe a little earlier than they were used to, because oftentimes we try and deliver those fundamental skills so they feel that they have some successes and they are able to acquire some of those, and then work on some of the higher level clinical judgment things. And we really had to shift those and saying, now we need to focus on these and you will pick up those later. So I think that was one of the challenges that we were facing. So I guess our next question is, what, have we been discussing in terms of some of these innovations and changes that we may like to consider continuing once we come back into our new environment. How about you, Joe?
Well, certainly much of the online learning will continue, definitely. And I think there have been noticeable changes, as I said earlier, in the way the students have responded, particularly the undergraduate students, to using these environments. I think one of the other things perhaps to point out, I agree with you with what you were saying about the steep learning curve for a lot of the staff members. We have universally adopted MS Teams, and that was very, very new at the beginning of March, and for us it was. And we are now working full-time on Teams. Many of us will spend 8, 10, sometimes 12 hours a day working on Teams, which in itself can be quite challenging, but we've rapidly become used to it. So I think for us as a university, we think that, for instance, we will not be back on campus now this year, we don't believe. And we think that going forward, much of the work will be done remotely, online, using resources such as MS Teams and Zoom. I think from that point of view, that's the main features for us. With regard to the students' confidence, they have very much appreciated being in practice. The second and third year students, I think we were all a bit concern to begin with, because they were going straight out into practice with very little preparation for what they were going to face. And as we all know, COVID-19, particularly at the beginning, was quite it was an unknown, and there were a number of challenges that we were not able to particularly reassure the students about, because we didn't know ourselves. However, I don't really want to say this too loudly, but we've been remarkably, it's been remarkably quiet with regard to how the students have responded, and they seem to all be very happy with their learning in this situation. So I think there's going to be a lot of reflection after this period is over on what particular skills and what particular attributes were associated with going into practice this early on, and what we can take from that to move it forward in the future and gain from that for our students who will come back to being students and not just employees. One very minor thing for them, well, a minor thing for it's perhaps major for them, is that while they're employed within the National Health Service, they're also getting their bursary. So some of them are doing rather well financially, which when that ends, they may find a bit more challenging to deal with.
So I think one of the things that we have increased and really noticed the benefit from was, I think some of the clinical people mentioned the importance of telehealth. We've increased that opportunity for our students to participate with telehealth in terms of their training. So I think as we're seeing that expand in the clinical area, we are preparing our students, especially our DNP students, more in terms of telehealth. I think as a faculty member, I really liked the opportunity to sort of mix it up. When you're in an in-person seminar, you may do some active learning strategies, but having that online component and be able to do some online versus some remote breakout rooms really, I think, gives more tools in my toolbox. It requires additional preparation and learning, but it's kind of fun actually to try and think about how you might engage students and differently, and what tools that you have to be able to use. So I actually think that we are planning for our PhD program to do distance program in the next year, where we will have some students on campus in person, and we will have some students distance. And this is sort of like practice when we hadn't even planned on it, to try out some new techniques and what we might do. I think our students miss their peer interaction and that cohort. I know they've set up their own, Zoom sessions, but I think just that running in the hall or stopping in a faculty person's office and popping in and asking questions, really not so easily done when you are remote. So I think that piece, and we've heard some of the clinicians talk about the socialization that they miss with coworkers, I think is something that we'll probably need to work on a little bit better in terms of replacing in some way. We are planning to have our students back on campus in the fall, though some of our classrooms are not suitable in terms of the distance they allow. So we expect that we will do in this multimodal method where we will continue some in person, quite a bit of remote learning. We're having small groups come back for their practice labs and their simulations. We've requested that our clinical sites allow our students back into the clinical areas in the fall, and we start in September, early September. The university will be providing students with PPE and with training in terms of using that protective equipment. But I think some of the issues, and we're getting positive responses, what the clinical agencies need to do is make sure they have the staff to supervise the students, and that they figure out how to get back in their teaching role in addition to their additional responsibilities. So for some of our clinical courses, we think that may have been primarily preceptor-based, we will probably move some of them over to more faculty instruction, just to help alleviate some of that burden and to help us reintroduce students in the clinical areas. Have you heard any plans for the fall, Joe? I know you said you think you're going to be closed.
For the staff, yes, we're very, very quick. Yes,
okay.
I think we'll
We'll wrap up. I'm sorry.
Yeah.
Thank you for that, Ashley. I want to move on to Gilbert, who is going to, Gilbert Liu, who I will ask Gilbert to please introduce yourself and your position and your usual practice. And you were going to describe some of the inpatient reassignments that were needed of some of the nurses in response to the COVID-19 pandemic that I think some other people have experienced. So welcome, Gilbert, if you would do that.
Sorry. Oh, okay. Hello. So I'm a nurse consultant in urology at the public hospital in Hong Kong Island East, and I've been on this position since 2014. And I'm also served as the Vice President of Urology Nurses Association of Hong Kong, Asia Continence Care Association, and Council Member of the Chinese Urological Association Nurse Committee to promote urology and continence care. And my settings coverage would extend throughout the hospital, clinic, and community settings. And I usually work in inpatient ward, day patient ward, and outpatient nurse clinic, and even community as well. And I also need to take care of all patients with voiding dysfunction, urinary incontinence, erectile dysfunction, urinary stone, and cancers in other 6 hospitals in our cluster. Thank you.
How has the, can you hear me, Gilbert?
Yes, thank you.
Okay, how has the pandemic and some of the precautions that are used affecting some of the other urology nurses in terms of their usual work, in terms of assignments or workload?
Oh, okay. Maybe firstly, I would like to explain what has been happened in Hong Kong in the last few months. Our initial cases recorded in January 2020 and was mostly imported or import-related cases. And clusters were observed in the local community involving large meal gatherings and other gatherings in February. And there was an upsurge in the number of COVID-19 cases in Hong Kong from the mid-March to late March, which was mainly due to much increase in imported cases, especially returnee from overseas countries. And the clusters of local acquired infection have been reported in the public venues or recreational premises since mid of March, and including large outbreak in bars, pubs, and karaoke. And finally, the number of cases has been decreased generously since early April. And start from January 25 this year, our hospital authority announced the activation of emergency response level in our public hospital in response to the latest situation of COVID-19. And we have activated several enhanced measures, such as the universal masking in all hospital and clinics, set up the influenza light illness sanitation area at the emergency department, and full personal protective equipment for aerosol generating procedures. And we need to enhance ventilation in the emergency and outpatient department and waiting areas, and monitoring the isolation facilities utilization, MO machine utilization, and the PPE alcohol hand rub supply. And also our infection control teams have revisited and offered an N95 respiratory fit test program to all healthcare workers. And we need to arrange temperature screening in wards, emergency department, and outpatient clinics. And further enhanced measures like visiting to ward, voluntary service, and clinical attachment will also suspend. And all the non-urgent operations and service will adjust since January 27 this year. Most of our incontinence clinics, all the service will also suspend, and only cancer service can be continued. Okay, so with the high bed occupancy rate, the hospital are endeavoring to transform the general ward beds to airborne isolation beds. And previously, most of our cases will be grouped into urology wards, but after this COVID-19 cases, the ward has been closed. We don't have any phases for our urology patients, and all of our cases need to deploy to 4 to 5 different general surgical ward. But my colleagues may be not very familiar to take care of them. So we need to walk around and around to educate them how to take care of our inpatients, okay? So there's some special thing is some of our patients will usually deny they have the travel history, and there's a travel history indicator added into our computer system so that we can enable us to know wherever a patient has traveled through Hong Kong control port and using the Hong Kong identity card. And this has been extended to the general outpatient clinic and also specialist outpatient clinics as well. Thank you.
And how have the patients and their families been coping with this? Are there some special services to assist them with some of the changes that they're experiencing in their care?
Okay, I think the major challenges of the outpatient, mainly the outpatient in Hong Kong, is the worry about the getting infected in the hospital. As a result, around half of our clinic patients have default. They self-default the follow-up, or they will just telephone us to postpone the follow-up during this period of time. They seem not very worried about the delayed procedure or appointments. They worry about the COVID-19 more. And most of our patients required admission will also worry about being infected, and the family, they worry about the family not able to visit them, so that most of our cases don't admit to the hospital unless they have a serious problem. And we are now try to use the mobile phone, iPads, to help them to communicate with their families. And we need to using all the things to apps to let them to communicate with their families. Especially some patients have to live for a period of time in a ward, okay, and their family cannot visit them. So that we use the iPad, okay, we use the apps so that they can see each other's. And apart from the patients' concerns, and most of our staff also concerned their family members getting involved in the virus. And we have a central command committee has approved some special rental allowance for our staff working at the high-risk area, okay? So they can have a temporary accommodation rental for around $500 per day. It is very good. So they can live in the hotel and no need to go back to home when they doing the dirty team or in a COVID-19 ward, okay? And our government also have the additional measures to recognize our effort, like they will have some special emergency response allowance to introduce our staff working at least 2 weeks duty in high-risk area or surveillance ward, and they are also eligible for the allowance.
Oh, that's great.
Yeah.
How would you say your practice has changed from maybe back in the February, March months until now? What were you doing now? And are you seeing some normalization for some of your work?
Oh, okay. So as the number of cases has been decreasing gradually since early April, most of our nurses has returned to their normal work gradually. And we have resumed our nurse clinic operation and most of our clinical service. We still have some nurses work in the isolation ward, as we still have several cases of COVID-19 being diagnosed per day. At present, there are around 590 cases and negative patient rooms in our public hospital, with around 1,000 negative patient bed activated. And we have total around 149 confirmed patients are currently hospitalized in 8 hospitals in Hong Kong. And we are also now applying some special honorarium scheme for the managing rescheduled clinical activities related to the COVID-19. So we need to perform some extra sessions in a Saturday to handle those rescheduled cases in the past few months. But however, in these recent few days, a new wave of some local infection cases with unknown source emerges. And therefore, we need to continuously combat the disease and safeguard the health of staff, patients, and members of the public by tightening the infection control measures in various aspects. Like we need to suspend the special visiting arrangement, and we need to resume the COVID-19 triage, the test center and isolation ward by status when necessary in response to this EPIC's development.
Well, thank you, Gilbert.
Thank you.
You know, that is a great lead-in for our final speaker, who is Veronika Geng from Germany. And Veronika, I'm going to ask you to introduce yourself, your place of work, how long you've been in the position, and you're going to sort of describe some of the reopening and transition. It's hard to say back to normal, but let's say transitioning that you are seeing in Germany. Welcome.
Welcome. Hello together. My name is Veronika Geng, and I'm a nurse and a scientist working in Germany in a foundation called Manfred Sauer Foundation. And the Manfred Sauer Foundation will give some meaningful life for spinal cord injured people. And therein I'm the head of an advice center for nutrition and digestion for spinal cord injured people. And in this job, I'm being since 15 years, working with spinal cord injured people since 35 years. So I work in the foundation. It's a building. We have a hotel. We have a fitness and wellness center, as well as a restaurant. And with the start of the lockdown or of the shutdown from COVID-19, we closed. And only my person was in the building alone. All the others are in home office, or they have to work in short work times. The restaurant was closed, the hotel was closed. And so I could do my work in a quiet rooms and in silent, because nobody others were in the house. And in my in part of the job, I'm in the board of the German Association for Spinal Cord Injured People, the medical association, and I'm also in the guideline group for the European Association of Urological Nurses. So I have also the not only the bowel problems as well as the bladder problems from the peoples. I can't hear anything.
Sorry. Could you describe some of the differences that you initially took in some of your precautions into what you're seeing now?
For my personal work, or for my work, I've did before COVID a lot of telecommunication. I have about 95% of my advices are on telephone. I call the people. I have talks about nearly an hour for the first talk, and then I go with them until their problems are solved. And so there was not a lot of change for me. In the first time, after 1 week, the lockdown has started, I have the impression that the people have more bowel problems because they are constipated. They are constipated because they are not moving, they have no sports, they have no physiotherapy. And so there was, I thought, oh, that may be a problem for the future, because a lot of people get problems with the digestion. But it was only the first, and then it comes back to the normal situation. In the time the lockdown was, the spinal cord injured people are locked them in. They don't go out of the house because they have fear, and they don't come to public places and things like them. And I had a very quiet time in this time. I have days there were no calls. Otherwise, I have 20 to 30 calls a day. So it was really a quiet time for me. And after the lockdown now, the people have a lot of problems, and the calls are more than before. So it changed. I don't know exactly why. And in the whole situation in Germany for the spinal cord injured people, the hospitals, the rehabilitation centers, and institutions which have spinal cord injured people, they have closed their hospitals in cases for new people. They only take over the fresh injured or the fresh people who are new in the situation of a spinal cord injury or disease. But for the people who has some rehabilitation aspects or things like this, they closed, so that they have enough beds. If there is coming a big problem for this group of people, that they have beds for them, for maybe ventilation, maybe for other problems of the spinal cord injured people. So we are well prepared for this group of people. And we did then a survey in the beginning of May, and we asked the hospitals, and we have 33 hospitals in Germany, Austria, and Switzerland in the German field. And we asked them how many beds they have closed, and some of them have really closed 50% of their beds to be aware if there comes a problem with the spinal cord injured. So they shut down the how you call it, the situation that you don't can in an ambulance situation. They closed them, and they only take over the emergency cases. So
no elective procedures, you're saying?
Yeah. So they have no ambulance and things like this for people who have controls and at this moment. And we also asked, we shut down at the 17th of March, and we asked at the beginning of May how many people have COVID-19 in these centers, and we asked 33 and 26 give some answer, and we have only 15 patients in this group, and from these 15 patients only one was for one night in the intensive care unit. All the others are nearly easy cases. So the big fear that spinal cord injured people are a big risk group because they have ventilation problems and they have breathing problems, they have the tetraplegia, but that wasn't real. So that was good to be prepared, but it doesn't happen like we have fear for. So, and since beginning of June, we are coming back to something like normality. The clinics are open with some restrictions. You have to be there only with one person with you. You have visitors one a day. And you have to register all the people coming into the hospitals and things like this. We always have to wear face masks, the hospital staff, as well as the visitors, as well as the patients if they're leaving their room where they are in the hospital.
So was the transitioning now in the summer, was there a group that had an overall plan, or was this left to the individual hospitals and clinics to plan? How is that working?
It was the individuals of the clinical worked individual, and we have some different situations in Germany. We have parts of Germany who have a big problem, and we have parts of Germany which have nearly no COVID patients. And so the law was not for all the same. There is on a regional level, they give some laws for the regions that they could open things, others couldn't do that because they have more cases, and it was restricted by the public, by the government, and I think it was well done like this.
And how are people responding to that? Are you finding that people are getting tired of it? Are they cooperative?
It differs from person to person, I think. Some of them are tired, and some of them don't understand what all happens, and others are very aggressive because they don't want to be locked in and things like this. And so there was a problem that also groups don't recognize the rules, and that this gives problems in total. But I think now coming back to normality, the people forget all the problems and go over the normal things, and that's a new problem.
Mhm. And how about for your group of patients with a spinal cord injuries? Have you felt that their families or the patients have, adapted and picked up some new knowledge or innovations about this in terms of their care that they might continue?
No, I think they really go not out of the house or of the apartments, and they closed in the family, in the near family. And I think they have problems with getting material because some things are sold out. They don't get material for catheterization, for disinfection, for example, or for hand disinfection, or masks for the people who care for them. And that was a problem. I think that was the biggest problem for them. And to be isolated, no meeting other peoples, and isolated with their own problems.
Mhm. And has your group begun to maybe offer some outlets for this, or some maybe virtual ways for them to maybe overcome some of that?
There are some organizations who did something for them. For example, a weekly workout in fitness for wheelchair users, or maybe some help to buy things or bring them things home. Also, it was offered to have something like a virtual meeting to talk about problems with them from the organization for the spinal cord injured. They do, and in the European field, there was an alliance which look for money, that they get money to buy masks for the high injured people, maybe the tetraplegic people who has nurses or who has family members who care them, that they get masks for free for each person, 50 masks. So there are a lot of good things happen, I think so.
Very good, very good. Well, I want to thank everyone for the informative discussion that we have had today. Anyone who is participating or will join us after this live presentation, there is the ability to send us some comments, and all of the participants will be happy to provide an answer offline. If you provide us with your email, or you want to use through the ICS website, we would be happy to answer any of your questions and really continue this conversation about your own experiences. I just want to invite anyone from our panel who has heard everyone else really for the first time. Do you have any follow-up comments or questions for anyone on the panel?
No, but just a comment, Donna, it was really interesting to see all the different countries, how they're coping, and the varying types of nursing, and how we've all come to adapt. And it's really nice to be able to learn from each other. So I really appreciated this too. So thank you for arranging it.
Thank you, Frankie. I agree. We really hadn't talked in detail about everyone's experiences, and I found it very helpful and fascinating how we have managed to meet this challenge and to continue to care for our patients and educate our students. So I want to thank everyone.
Thank you for having us.
Yes.
Bye, everyone.
Bye.
Bye.
Bye.